Thank you very much, Superior. Hello, everyone. I would like to start with commending you for your decision during this webinar on influenza, because you are really looking into influenza beyond the COVID, which has been overwhelming in the past 3 years. Yes, already, almost 3 years already. So this webinar is the first of a series of webinars on this topic of influenza and those related to influenza. Those related to influenza, including the respiratory concerns or respiratory viral infections that you might have. So the future topics we would select based on the need and also based on the evolution of the situation with the upcoming influenza season. But in today's webinar, we'll cover some of the most prominent aspects related to influenza, and me and my panel here connected in this webinar, we will try our best to address your concerns and your questions. So with this, let's start. I will do some of the basic introduction, and then I'll pass over to other panelists. Superior, would you be able to run the slides? Okay, yes, it shows up here. Next slide, please. So what is influenza? I think in a simple word is that influenza is a killer because it kills. And of course, influenza is a serious viral, it could be a serious viral infection. Sometimes we call influenza also referring to the virus itself causing the disease. But influenza, well, it is a disease or a viral respiratory disease. So influenza is not equal to common cold that we are all talking about, because there are many other respiratory viruses or bacteria also causing respiratory infections. But as I said, influenza is a killer, because it can cause serious illness and also death. But for influenza, we have safe and effective vaccines available for seasonal influenza. And we also know influenza virus is constantly mutating. And we know that there will be a next influenza pandemic. Next slide, please. So why we are concerned about influenza? Influenza is a killer because every year it can kill up to 650,000 people. And this is only the respiratory deaths. Of course, well, it causes even more, around 3 to 5 million people hospitalization. It's a severe diseases. And it's a burden in the lower and middle income countries even bigger. And we are working, WHO is working with countries trying to get a clear picture on what exactly is the burden associated with influenza. And probably you've heard that during COVID, seasonal influenza was gone. Now it's no longer the case. We can see from the chart that after certain years, the chart starts from 2018. So we can see the season, influenza season, it's very obvious. But starting from early 2020, influenza circulation was very low. But starting from the second half of 2021, seasonal influenza comes back, as you can see from the chart. So it is back. Next slide, please. Then the question of what causes influenza, or let's take a step further into what are the viruses causing such diseases and sometimes also death. So far, we know that there are 4 types of seasonal influenza viruses, actually 4 types of influenza viruses, not just seasonal. So 4 types of influenza viruses, A, B, C, and D. Influenza A and influenza B viruses circulate and cause seasonal epidemics of disease. Influenza A also circulates in animals and can infect people. And when it occurs, we call that zoonotic infection. So zoonotic influenza or some of the influenza A viruses are also zoonotic influenza viruses and can cause zoonotic infection. And only influenza A viruses are known to have caused pandemics. Next slide, please. So how many types of influenza we're talking about? We know that there's seasonal influenza, which is caused by seasonal influenza viruses, and it comes in season, and usually we're in the winter season. So we call in the northern hemisphere influenza season, southern hemisphere influenza season, and in tropical areas it's all year round. And also the avian influenza. So avian influenza, it is an influenza caused by like avian influenza viruses, by swine influenza viruses. It can sometimes cause infection in human, but so far most of those infections are sporadic. And then the pandemic influenza. So we know that the last influenza pandemic was 2009, and it was caused by a novel strain of H1N1 influenza A type of virus. Next slide, please. Then about avian influenza and the pandemic influenza. So we said that during COVID pandemic, seasonal influenza was very low, and in some of the areas it almost disappeared. But by contrast, the zoonotic infection actually continued. It's continued throughout the COVID-19 pandemic. And the more of that is that some of the first infections of new subtypes, for example, H3N8 and H10N3 was reported during this COVID pandemic. And these reports were coming from China. And also first human infection with H5N8 subtype of avian influenza virus was also reported for the first time from Russia. And in UK and US, human infections of H5N1 subtype of avian influenza also reported for the first time. So all these phenomena sending off a signal, and it means the threat of an influenza pandemic. It persists throughout the COVID-19 pandemic. Because of that, all of us, countries, or all of us should never let down our guard against such threat. And meanwhile, strengthening the preparedness for the next upcoming influenza pandemic. Next slide, please. So now is October, and if like normal season, influenza activity should be starting now, and also the Southern Hemisphere season of 2022 just passed. So what we've seen from the past Southern Hemisphere is that influenza epidemics did come back, and actually it comes back to the equivalent level of before COVID pandemic in the Southern Hemisphere, and in some countries even more severe or upper than the levels of pre-COVID-19 pandemic in some Southern Hemisphere countries. So what exactly the situation would be in the Northern Hemisphere, well, it's yet to see. But the surveillance of WHO certainly is continuing, and we all need to maintain the alert for this. Next slide. I guess that's okay. So I'll stop here with regards to introduction of the topical influenza and pass over to Dr. Eduardo Aziz Bombgata from CDC to tell us the symptoms of influenza and SARS-CoV-2. Eduardo?
Thank you so much, Wenqing. Influenza virus particles often spread from person to person when they cough or sneeze. The mist of virus particles can be breathed by others who are in close proximity, like within a meter. Influenza virus particles can contaminate surfaces, when an infected person wipes their nose, for example, and then touches a doorknob. To prevent transmission, persons should cover their nose and mouth when sneezing or coughing. And persons should wash their hands regularly to avoid touching the mucous membranes of should wash their hands regularly and avoid touching the mucous membranes of their eyes, nose, and mouth. Next slide, please. Influenza symptoms can include rhinorrhea, cough, myalgia, sore throats, headaches, fevers, chills, fatigue, difficulty concentrating, shortness of breath, earache, wheezing, nausea, and diarrhea. Symptoms are indistinguishable from COVID-19 and other respiratory viruses. Illnesses can last 1 to 2 weeks. And while persons typically get better from influenza, less than half seek care, they're often associated with substantial absenteeism and presenteeism from work or school. That's when people show up to work with symptoms or have to miss work because of symptoms of influenza. A small percentage of cases progress to severe illnesses or death. But because influenza has such a high attack rate each season, these small percentages accrue and represent hundreds of thousands of influenza deaths each year. Next slide, please. Both seasonal influenza and SARS-CoV-2 infections can progress to severe illness in similar risk groups. For example, persons with certain pre-existing conditions such as cardiovascular illnesses, chronic lung diseases, etc., can have severe complications as a result of influenza or SARS-CoV-2 illness. There are few notable differences in risk groups. For example, we see a classic U-shaped curve when we look at the risk of influenza by age group, where we see that the very young and the very old tend to have the highest risk groups for hospitalization. This seems to be less the case in COVID-19, which tends to affect mostly older adults and seems to spare the very young to date. It is useful to keep in mind that these groups, because when you're crafting risk communication messages, it is helpful to know who might be at greatest risk and may need to be mobilized for vaccination or care. Next slide, please. One might ask if it's possible to get influenza and SARS-CoV-2 co-infection, and it is certainly possible. Both have been documented, for example, in FluNet. These occurrences do happen, but they're very, very uncommon. What is most important to remember is that the prevention of COVID-19 and influenza is similar. One ought to get fully vaccinated both against influenza and COVID-19 whenever possible. And if one develops illness or danger signs such as shortness of breath, confusion, chest pain, one ought to contact the provider as soon as possible for triaging and antiviral treatment. Antivirals are available for both diseases and must be taken as soon as possible after illness onset if they're to work. Every hour counts. Next slide, please. All right, I don't see the deck advancing, but one may ask if one can differentiate influenza from COVID-19 by their syndrome, but there's really little predictive value in individual symptoms. And the only way to know one has influenza or COVID-19 is to get tested. And as a reminder, again, if you have critical illness against critical symptoms, it's important to seek care because you may need ventilatory support or antivirals. Seasonal influenza and COVID-19 is treated through specific antivirals. There are 3 drug classes that are approved for influenza treatment, including adamantases, neuraminidase inhibitors, and polymerase acidic endonuclease inhibitors. Of course, adamantanes are not used anymore because of resistance, but the 2 other classes are useful. Neuraminidase inhibitors block the viral neuraminidase enzyme in both influenza A and B type viruses. And baloxavir marboxil is a polymerase acidic endonuclease inhibitor approved by the FDA for a treatment of uncomplicated influenza in otherwise healthy persons aged 12 or older. Now, a Cochrane review of randomized placebo-controlled trials in adults and children with influenza reported that zanamivir, an inhaled neuraminidase inhibitor, reduced the symptomatic disease duration among adults by 0.6 days, while oseltamivir, or Tamiflu, an oral neuraminidase inhibitor, reduced the disease duration among adults by 1.3 days. Now, there was no significant difference in either drug on the illness duration among children. Now, this is all true, and the Cochrane review is very important, mostly for outpatient illness. Operational data during 2009 suggests that using antivirals was associated with lower risk of progression to severe illness, including reduction in mortality risk among hospitalized patients with influenza. Next slide, please. Passing it on to Chris.
Thank you, Eduardo. Hello, everyone. So as many of you probably know, the best way to protect yourself from influenza is through vaccination. And so seasonal influenza vaccines are actually widely available. They're safe and effective and have been used for decades. However, immunity from the seasonal influenza vaccine does wane over time. So WHO does recommend annual influenza vaccination to protect against influenza. And there are several types of influenza vaccines used, but it's actually the injected inactivated influenza vaccines that are most commonly used throughout the world. Because the vaccination does wane and we do see circulating influenza viruses change over seasons, the composition of influenza vaccines needs to be updated periodically. And that's based on WHO recommendations that are informed by the surveillance through the Global Influenza Surveillance and Response System. And most recently, on September 23rd, 2022, WHO issued the newest set of recommendations for the composition of the influenza vaccines for use in the 2023 Southern Hemisphere influenza season. And so manufacturers will soon start producing vaccines for that season based on the WHO recommendations. Next slide, please. WHO has an advisory group, this strategic advisory group of experts on immunization that guide all immunization and vaccination policy for the WHO. And most recently, SAGE issued a set of recommendations for influenza vaccination. And so WHO published its new position paper in May 2022. And WHO has recommended annual influenza vaccination for decades, but this was an update to existing position papers. And we recommend that all countries consider implementing a seasonal influenza immunization program, not only to protect the vulnerable, but also to strengthen their vaccination programs and also to provide a good foundation for pandemic influenza preparedness. In those recommendations in the position paper, we do note there are populations that should be prioritized for influenza vaccination. And those include children, health workers, individuals with comorbidities and underlying conditions, older adults, and pregnant women. So as we've said, we recommend annual influenza vaccination program, and that should be just prior to the influenza season. And so for the Northern Hemisphere season, that's typically in October, and for the Southern Hemisphere season, that's in April. However, there are countries in the tropical and subtropical areas of the world that experience influenza activity throughout the year or have sort of atypical seasons as we might know it in the Northern Hemisphere or Southern Hemisphere season. And that the WHO recommends that the influenza vaccination programs be set up and vaccines administered just prior to the start of the primary period of influenza activity. And so it will really be your countries that have a policy in place that determine when that timing for influenza vaccination is. Next slide, please. And so as you heard from Eduardo, there are certainly ways to prevent both seasonal influenza and COVID-19 as we've seen these last few years. Of course, vaccination for both are recommended and encouraged. And in fact, WHO has a standing recommendation that during the same visit, both the COVID-19 vaccine and seasonal influenza vaccine can be administered at the same time. In addition to vaccination, as we've seen through the slides and as we've heard, public health and social measures that have really been promoted and encouraged and implemented for COVID-19 are also effective in preventing seasonal influenza. And of course, that includes good hand hygiene, respiratory etiquette, physical distancing, and mask use when recommended. I think that is my last slide. I'll hand it over to Dr. Aspenhammond. Thank you.
Thanks, Chris. And so now I'm going to switch a bit and discuss some general information on influenza surveillance and also on the co-circulation of influenza and SARS-CoV-2. So globally, influenza detection and monitoring is coordinated through a global network called the Global Influenza and Surveillance Response System, or GISRS. GISRS is a network of almost 160 institutions in over 120 member states of WHO. And here you can see a map of the locations of these institutions. And with and through national influenza centers, or the laboratories in countries and their partnering public health institutions, and the larger network they're part of, influenza activity is monitored locally and globally. And many countries run what we call syndromic surveillance, where patients are identified who meet a certain case definition or have a certain set of symptoms. These cases are registered in surveillance, and respiratory samples are collected from them. And the respiratory samples are tested at the influenza centers for influenza and other respiratory viruses as part of this routine surveillance. Influenza virus detected as part of the surveillance are studied in the labs of the network to better understand which types of viruses are infecting humans and what their characteristics might be and how they might be changing over time. Having a global network is important, as these influenza viruses know no geographical boundaries, and influenza is therefore a global problem. And a key role of this system, this network, is to make recommendations on the viruses to be included in the seasonal influenza vaccines, as Chris said. And this deliberation and decision is made twice a year, as mentioned. And so currently, where do we see influenza activity? Might be a question. Luckily, at this point, global influenza activity is quite low. We are at the time of year where usually the season in the Southern Hemisphere is coming to an end, and just before the season in the Northern Hemisphere is beginning. But we have to caution that with the ongoing COVID-19 pandemic, influenza activity is not following always the typical patterns that we've observed previous to the pandemic. And this map is a recent map that shows the proportion of samples testing positive for influenza by region, with the darker yellow indicating a higher proportion of samples positive for influenza. So we can see there's still some areas with a bit darker shading of yellow. You can see some activity in South Africa and Southeast Asia. And of course, in some of the non-temperate areas, influenza activity is often reported year-round or multiple epidemics in the year, as we said. And the map also indicates an important aspect of which viruses are circulating in which regions. And we can see in the period this map shows that H3N2 seasonal viruses are predominant, but that varies by season and the time of the season. So in order to keep track of this and report this information to the world, the Global Influenza Program produces updates on seasonal influenza activity every 2 weeks based on the data reported to us by countries. Many countries also report the status of influenza activity in their own national bulletins. And the next question is where and how do influenza and SARS-CoV-2 circulate at the same time? And since the emergence of SARS-CoV-2, WHO's Global Influenza Program and the GISRS network have encouraged countries to monitor COVID through their existing influenza surveillance systems so that we can keep an eye on the relative circulation of these viruses. And what this means is that the labs who are testing the samples they receive as part of surveillance test those samples for SARS-CoV-2, in addition to flu and other respiratory viruses that they routinely do surveillance for. This information is reported to WHO, and so that we can make examples, charts. The examples are shown on this slide. The top chart the top chart shows an example from a country with the top graph indicating the influenza viruses by subtype circulating, and the middle graph in red showing simultaneous SARS-CoV-2 detections from the same system. So we can see in a country the relative circulation of these two different viruses. And finally, the bottom chart is showing the global trends in influenza detections and SARS-CoV-2 detections. So we can see that for a large part of the pandemic until late 2021, influenza was very low, but it has picked up again, as Wenqing said, and I'd like to highlight the continued surveillance and appreciate the continued surveillance that countries are doing in order to follow these viruses. So I'll just conclude a bit summarizing what colleagues have presented in the previous slides, that we just want to emphasize influenza is a serious pathogen to monitor. It does cause respiratory infections, some of which can be severe. They spread easily from person to person. The symptoms are often very similar to symptoms of COVID, and diagnostic testing is really the only way to differentiate between infection with these two viruses. It is possible to get co-infections, although luckily the incidence of that seems to be very low. But vaccination against both infections is the best protection. And treatment for seasonal influenza is often symptomatic and supportive unless there's severe or complicated disease occurring. And just to highlight again, the Global Influenza Surveillance and Response System, or GISRS, is coordinating global influenza surveillance and collecting data and reporting that back to the public. And we have seen that influenza activity has picked up once public health measures are lifted in certain places, but that activity is occurring with different timing and intensities as may have happened before the pandemic. And activity has reached levels that we've seen before the pandemic in some countries. And that we know that both these viruses can circulate at the same time in countries, again, emphasizing the importance of continued surveillance. That's the summary. I will hand it back to Wenqing to moderate the question and answer. Thank you.
Thanks very much, Aspen, and thanks to all the panelists. So now we are coming to the Q&A session. Just to be kindly reminded that if you have questions, please put your question in Q&A. There's a button, well, on my screen is at the bottom, not on the chat. So we're monitoring the questions coming in the Q&A box. So let's start. There's a comment from Isatu Sa on the seasonal vaccines, the modernization of the antigen production. For this, I ask Chris to comment, but I will comment on developing models that are better at predicting virus evolution. I fully agree with you that we need to develop more models to predict what is going to be upcoming. But model does not necessarily mean statistic model, because we still need to do a lot of basic research. There's still a lot of unknown of how actually viruses are evolving at the molecular level, at the biological level. Well, we are still a lot of unknown. So we need to develop those. Meanwhile, developing models to how to use all the data are being generated, try to project what's going to upcoming. Prediction maybe is a little bit remote, but projection is more, let's say, realistic, that can be achieved in relatively short period of time. I pass on to Chris to comment about modernization of antigen production.
Sure. Thank you, Wenqing. Yes, so I didn't cover it in the slides, but we have widely available, we have inactivated influenza vaccines, live attenuated influenza vaccines, and recombinant influenza vaccines that have been approved in various countries. There are certainly efforts underway to improve those products themselves, such as, and I put it in the Q&A for a different question, but for example, we have adjuvanted or high-dose influenza vaccines that are intended to be used in the older populations to provide greater vaccine effectiveness for that population. But there's also substantial efforts underway to get to the next generation of influenza vaccines. And these include those that are broadly protective, so they cover multiple influenza virus strains, as well as the universal influenza vaccine that we would all really want to see sooner than later. And those we would hope would cover all influenza viruses for multiple years, providing the protection greater than just the 1 year that we see. But we certainly encourage continue research on the current products we have now because they are so widely available, and there's so many opportunities to improve those rather than only focusing on the newer platforms. But we welcome all research and improvements in influenza vaccines.
Thanks, Chris. We also have a question from Madian Mamon. The question is any alert of emerging influenza mutants? I think what any emerging genetic variants of influenza. I think the answer, well, in a simple way, is yes. Influenza is constantly evolving. So basically every second, well, there will be, and even virus, when a virus infecting human, it's a virus replicate inside the human body. Those replicated virus also will be different from was original or the first virus infect human body, because this is decided by the nature of the influenza viruses. So yes, and because of that reason, vaccine compositions need to be updated. And also because of the reason there's a threat of the next influenza pandemic. You know, viruses at the moment are in the animal reservoir, in animals, but if a little bit mutant, just a few amino acid changes, it might jump out and infecting human. And this is why influenza is so important, from public health perspective. Let's move on. What is the impact of low activity seasons on future spread and vaccine mismatch? Maybe I'll comment on vaccine mismatch, but on future spread, Aspen, would you like to comment on that?
Thanks. I can try. I think it's a good question, a question that we all would like to know the answer to, but I think it's hard to give an exact answer. If we could look into the crystal ball and we could plan, that would be great. But I think that there's a couple things, as you mentioned. There's potentially lower immunity if people have not seen influenza viruses in a while, then they could be more susceptible to what's coming. People on the good side, people may have changed their behavior. They may be washing their hands more. They may wear masks more. So potentially there will also be some protective effects too from the experiences that we've gone through. I think having seen the information reported from the countries in the Southern Hemisphere over recent months, we've seen that in several countries they had what would be a fairly usual influenza season. So I don't think that we can expect that it will that things will get that flu will disappear and that we won't have to deal with this. It will continue to be a problem. So yeah, but in terms of when and which viruses and how bad, I think that's difficult to predict.
Thanks very much, Aspen. Yeah, also to add, because of the low circulation in the past 2 years, let's say, it has created some of the immunity vacuum in the population. So it makes basically the next upcoming influenza season more unpredictable. And this unpredictability will maybe also include the timing. You know, usually it comes like in November. It might be earlier, and it did happen in the Southern Hemisphere this year. And also on the severity as well, it might becoming a severe epidemic. So as Aspen said, that we're yet to see. But again, one thing is that we have safe vaccine available. It can provide protection on those. So the question about mismatch, actually, it's a good opportunity. Like, let me tell you, the wording, the concept about mismatch is not really scientifically sound at all. Influenza virus is evolving. Seasonal influenza is evolving. It's not jump. Jump means it will cause a pandemic. So if seasonal influenza virus is evolving, well, virus selected at this level, for example, could provide protection, cross protection one of the other. So it's not match, mismatch, well, two choice, yes, no. No, this is not really well accurately if we're talking about mismatch. Also, of course, the word is easier, to just to say match, mismatch on that. But the lower activity, not this year, in the past 2 years before 2021, it did create some of the difficulties when we tried to select the virus that need to be included in the upcoming season, because it provides some of the limitations of the broad understanding of the virus evolution and circulation in the globe. However, although the virus low circulation and also surveillance was disrupted to some extent because of the response to COVID-19, WHO, we did have the overview with regards to virus evolution and also the new emerged genetic clade and also antigenic clade. And we actually changed the vaccine composition, one of the components during the COVID as well. So it does have, let me say, it did have some impact on the virus selection for the influenza vaccines. But since middle 2021, influenza activity picked up. So actually, we're at the moment, basically, there's enough sufficient information to make a decision about the vaccine composition. I hope this addresses your question, Mohammed. So let's move on. Additional booster dose is required. I think it relates to influenza vaccines. Maybe, Chris, would you want to comment on that?
Sure. Yes, thank you. Yes, absolutely. So every single year for the majority of populations, you get just the one dose. For children, for their first vaccination, they will receive 2 doses, but otherwise it's just the one dose influenza vaccine every year.
Thanks, Chris. So next question about what are the vaccines cleared by WHO so far? I don't know what does that mean, cleared by WHO so far. Because the influenza vaccines are regulated by national and regional regulatory agencies. I don't know what does it mean cleared by WHO so far. Maybe are you referring to pre-qualification? So Chris, maybe you can have a comment on this. And also the second half of the question, it's jumped on my screen. Yeah, I don't know why it jumps. So the question jumped.
Sure, I can
guess that.
I'm trying to find it as well, but I can't find it. Just to note that, yes, WHO does, as part of WHO's function, we do pre-qualify vaccines, which this pre-qualification is especially helpful for the procurement of vaccines by other UN agencies such as UNICEF. And so there are a number of seasonal influenza vaccines that have been pre-qualified by WHO for many years, and additional ones are regularly assessed. And so you could go to the WHO pre-qualification website to see that full list. But as Wenqing said, this does not replace the national regulation of vaccines. It's an additional activity for that UN procurement.
Thanks very much. Chris. Let's move on then. So the next two comments from Sar is about surveillance. You're absolutely right. The integrated surveillance by GISRAS is using the minimum, I would say, resources, try to monitor the co-circulation of the viruses. For any country, the relative proportions of circulation in the country is very important in order to make a decision. So yes, your comment is absolutely right. And then you have another comment about the interaction of different circulating viruses, and this also linking to a question somewhere, why influenza circulation was low during COVID-19 pandemic. And I think, well, of course, at the visible levels, that the non-pharmaceutical intervention or public health social measures certainly played a role of the virus circulation itself. But there is another aspect of the reason is at the molecular reason, at the immune system level. It might be due to the non-specific immune mechanisms, for example, the interferon itself. Because, if we look back the past years of the respiratory virus circulation, we've observed that if influenza virus, for example, circulating at a very high level, RSV is not. And if RSV, which is also a respiratory virus circulating at high level, then influenza virus, circulation is not. So viruses are competing with each other, but of course there are other respiratory viruses, for example, para-influenza, where they are circulating irrelevant to how high of RSV and influenza. And during the COVID-19 pandemic, also in many countries, rhinoviruses continued circulating itself. So these are the reasons, mixed with regards which one is higher, which low. Or maybe Aspen also mentioned, where in the Southern Hemisphere season, we've observed the influenza activity in South Africa. Influenza season started at the end of last year, although it's earlier than usual. Then it declined because Omicron started circulating. And then since April this year, influenza came back again. You see, so there's a lot of competition of the circulating viruses itself. I hope this addresses your comments as well as a question, or maybe from somebody else. The presentation and recording being shared with participants, and I think this question is for Sukaria, if you can.
Yes, all the presentations will be shared with participants. The recording is on our YouTube channel, as well as it will be on our website soon after this. So you will be able to access the recording of this webinar as well. And the PDF of the presentations will be shared with all the participants.
Okay, thanks, Sukaria. Let's move on. There's a comment about the origin of coronavirus, whether it's caused by laboratory accident in Wuhan or some experiment with gain of function. I think this is already beyond our scope of this webinar. However, there's working groups established to look into the origin of the SARS-CoV-2 virus. Maybe you can follow up on the development on that stream. Then the next one is, if catching both influenza and COVID-19 at the same time, what type of antiviral should be chosen for hospitalization patients? Maybe I'll refer to Eduardo.
Wenqing, one more time. I'm sorry, I didn't hear the question.
Yeah, it's a long list of questions. It's hard to locate one. So the question is that if catching both influenza and COVID-19 at the same time, what antiviral drugs would you recommend?
Yeah, there's two different kinds of antivirals that are used for influenza and for COVID-19, and presumably one could use one of each. I am unaware so for example, you could start somebody on Relenza, for example, for COVID-19, when they're in the hospital, it's an IV drug, and then also Tamivir in the hospital. So I think one would have to use 2 different antivirals for a co-infection. But having said that, I think co-infections are exceedingly rare. And so I suspect that this is going to be an infrequent occurrence.
Thank you very much, Eduardo. Let's move on to the next one. Is a question from Nigeria. The question is why we're not taking risk communication and community engagement as a major tool to prevent and control this deadly disease. I think certainly, we are taking parallel approaches to handle the deadly diseases, but maybe Supriya, you want to comment about the risk communication and community engagement? Even like we are organizing a webinar today, it is part of the efforts, but Supriya, please.
Thanks, Wenqing, and thank you for bringing this up. I'm very glad to hear that about your concern for risk communication and community engagement, because we do believe that it is essential for communities to be engaged in order to prevent and protect from influenza as well as from COVID-19. We are working on it, and as Wenqing said, this is one of the many initiatives we are taking, having webinars like this, having updates on the web. We're also working with our colleagues at the country level and at the regional level to address your concerns, and there are various activities going on at the country level that includes more community engagement to make people aware of influenza. It's reaching out also to health professionals and health workers so that they can create awareness of influenza in the other country level, and of course helping countries to build capacity for risk communication in this area. Those are some of the initiatives we're taking, and it is critical. So thank you very much for the question.
Thanks, Supriya. Let's move on to the next one. Is about influenza vaccine composition. If B vaccine in the human influenza type B vaccine as a component of the childhood preventable prevalent vaccine in routine immunization. I guess the question is that whether you would want to include influenza vaccine, especially the B component in the childhood vaccination program. Maybe this is what you want to ask. And on this, I don't know if Chris, you want to add anything?
Thank you. Yes, so if I understand it correctly, if influenza vaccine can be part of the EPI childhood vaccination programs, and that's certainly something that we've identified as an option for countries, that it could be a way to effectively and efficiently use those programs to also vaccinate young children with influenza vaccines. Certainly it's an option. I'm not sure how many countries do it, but there are certainly examples of countries that have done it and continue to do it. Thank you.
Thank you. And the next question about pandemic preparedness, basically about the transmission of those viruses, etc. So yes, there are consultations going on really to look into the mode of transmission. And I think the idea is to look at the effectiveness of the transmission by different routes, then to check or to review the prevention or the measures that need to be developed targeting those. So this is a work we're going on, and it's right. WHO is doing that. The next one is climate change, impact on climate change, from climate change on the evolution of influenza viruses. Eduardo, do you want to comment on that? Climate change?
hard to predict what's going to happen. Of course, we do see that there's a strong association between the circulation of influenza and seasonal parameters, for example, temperature, absolute humidity, etc. But it is difficult to predict beyond that what changes in climate will do to influenza circulation. Furthermore, it's not clear exactly what are the pressures on the virus circulation that is causing the association between seasonal influenza circulation and the timing because of climate factors, right? And so, for example, if we don't really understand in the tropics the reason that seasonal influenza occurs often between May through September in the southern hemisphere tropics is because people may be spending time indoors or for some other reason, and not understanding therefore what are the drivers. It makes it very difficult therefore to predict once climate change starts to create processions on those climate seasons, what would be the impact on viral evolution. I think what is known though is that we need to continue to work together to have robust influenza surveillance systems so that we can track the relatively unpredictable course of influenza, and so we can be best prepared to have the correct variants in the vaccine, and we can be ready to vaccinate in the beginning of each season. I think that is clear. We need good surveillance moving forward, working together.
Thanks very much, Eduardo. Then another question is about how much data needed to create the next seasonal vaccine. I think basically what you wanted to ask is that how much data would be sufficient to recommend the next influenza seasonal influenza vaccine composition. I think the data, of course, ideally is the global, representative, and because the current vaccine technology, it will take 6 to 8 months to produce, i.e. that 6 or 8 months before the season, before the use of vaccine, we have to decide already what viruses need to go to the vaccine. So in this case, it creates a lot of challenges for that, but the most valuable data would be the latest. As latest as possible, the data include epidemiological data, virology data, the virus evolution data, so that we can check how far the virus already evolved away. And also the vaccine effectiveness data, that to check how good or how bad was the past vaccine are being used in humans, so that all these data are coming together, would be able to recommend the next vaccine's composition. The next question is about the typical picture of the post-influenza sequela. I guess this is a question, maybe Aspen, you can give them the answer, the typical or pattern of influenza in the past.
Actually, I might pass that to Eduardo. I think it's the influenza sequelas in terms of clinical signs, I think.
Yeah, I think there's a lot of sequela that occurs after respiratory viral infections. We are very familiar, of course, with COVID, post-COVID conditions, but influenza also has sequela after illness. And so, for example, people who have severe influenza can have a protracted period of shortness of breath after their illness. There's also been documented neurological sequela after illness that is subacute, and it can take a long time for people to get back on their feet with influenza. However, lasting impact from influenza, like long-term impact from influenza, is a relatively rare event. Now, of course, rare events in influenza can still accrue, right? Because the influenza illness is such a common occurrence. And so even rare events can accumulate over time. But there are sequelae as per respiratory illnesses, including influenza, that can hit multiple organ systems.
Thanks very much, Eduardo. Let's move on. The lessons we've learned from COVID that can be applied to influenza, the next influenza pandemic. maybe everybody, all of the panelists want to say about that. Maybe let's start with Eduardo. What lessons, maybe top 3 lessons you'd
from the COVID pandemic for influenza prevention? Yeah, I think there's a lot that we've learned. I think that in some of the chats there I saw somebody put a note about transmission of respiratory viruses and trying to better understand what is the proportion of transmission that occurs through droplets and contact versus aerosol transmission. I think that is something that we still need to unpack. I think the person who put that in the chat is correct. I do think we also learned a lot about the potential value of non-pharmaceutical interventions and teasing out, of course, what is effective and what is applicable during a seasonal influenza time period versus a pandemic emergency. I think we still need to explore this. For example, some of the interventions are non-tenable during an epidemic period. For example, we would love to, for example, have mass gathering restrictions or travel restrictions during a seasonal influenza epidemic. That would be non-tenable. But others may be useful, like, for example, should we be masking indoors during the influenza season in addition to doing hand washing and whatnot? I don't think we know the answers yet, in part because we don't know the magnitude of effect with great certainty, because a lot of the data was observational and ecological, but I think we need to understand that better. And I think we learned a lot also about how to nimbly stand up surveillance systems, about how to move data around, how to modernize data. So many lessons after the COVID-19 pandemic that will help us strengthen our preparedness for respiratory viruses. Over.
Thanks, Eduardo. I don't know if Chris, you want to also add some lessons, maybe 1 or 2.
Sure. I think I'll continue with influenza vaccines and vaccination. I think we, of course, all saw incredible global efforts to develop these new, COVID vaccines for a pathogen that hadn't been seen before, and we saw so many, several new platforms being utilized for the first time with an approved vaccine. So I think we'll certainly see greater emphasis and focus on these new platforms for influenza vaccines, for influenza vaccine development. And so that'll certainly be an exciting time for the research and development of influenza vaccines. And also for influenza vaccination programs. For years, we've said that having a seasonal influenza vaccination program is really a nice foundation for pandemic influenza preparedness. But we've also actually seen some countries, well, several countries through the COVID pandemic, they utilize that seasonal influenza vaccination program to deliver COVID vaccine programs, because there is so much overlap in high-risk groups. And so I think we'll really be able to continue that message and really highlight the importance of influenza vaccination programs to protect the individual against seasonal flu, but also to stand up all of those systems that can be leveraged during a pandemic. And so we have a lot of room to grow in strengthening that messaging and the programs for the future.
Thanks, Chris. I think we're already due to the end. There are still a couple other questions, as well as very nice comments about communication on influenza, or in comparison with COVID, is really poorly done. I think today's webinar is one of a series of such webinars meant to improve the knowledge and understanding of influenza for that. So hope if you can also join our future webinar on influenza, it will be great. And we really enjoy in discussion with you in this platform. So maybe with this, I would like to thank my panelists for today in the webinar, and also would like to thank participants for being so active. We're in the discussion. For some of the questions, we'll write back to you of the answer to the questions you asked. I pass over to Supriya to close the webinar then. Supriya.
Thank you very much, Wenqing, and I echo what Wenqing said. Thank you very much to all the participants, and also particularly to our panelists for the excellent presentations and for the wonderful questions. I think we had a really rich discussion. I'd like to let everyone know that this is the first of a series of influenza EPI-WIN webinars that we are planning. We hope to have one, more than one in the coming months, hopefully once a month. And I hope you will join us there and have all your questions ready as well for our experts. It's been great. Thank you very much. And thank you for bringing up the issue of communicating on influenza. There is a perception issue that people feel it's not as serious, not as important, but it is. And I think together we can work on this, changing this perception and having it taken more seriously by people. And I hope to see you next time. But before we leave, I'd also like to thank my colleagues who've been working in the background, Jupika Latinovic, Catherine Sheridan, Jiangfang Liu, and our interpreters, Mary Paul Wagner and Tazara Stafford. Thank you for all your efforts, and a particular thanks to Aspen Hammond, who has been organizing the slides and the agenda for this webinar. Thank you and see you next time.
Thank you. Goodbye.
Bye.